members of the Pediatric Society, you may find a mentor in Dr. Princess Echambo. Among many accomplishments, she is the founder of Women in Public Health and is very fluent in both English and French. So she is an international lecturer and a researcher. So let me stop here with the accolades and hand over to our presenter and for her to do justice to our topic. So Princess, thank you very much for accepting to deliver this lecture. And we are very grateful to have you. Thank you.
Thank you too very much for having me. I've put on my camera so that at least you'll see me a bit before my camera goes off. I would like to welcome you all for being a part of this. I would always say that even if one person understands, it's perfect because it still goes a long way to make a difference. And so I welcome all of you who have joined this evening session, having in mind that it's a big holiday for all of us. Independence Day is just tomorrow. People will be traveling here and there. And so I'll be very sensitive to the time and make sure that we move on and make it also interactive. So all those online, I'm not going to do this alone. Anybody who knows me knows that I would get you to speak and you'll be part of the process. In this lesson, we will have some scenarios. We will have stories that would help us understand and relate to pediatric research and for wherever we are, community and the people we deal with. So it's going to be very practical. It's not going to be that didactic than mentioning the big words. We are going to make it very practical, such that if this is your first time of being a researcher, you can still understand us. And so it's to inspire you also into doing research. You are very well placed if you are a pediatrician to gather a lot of data. If you have so much data and you have nothing to do with it, just call upon me and we will find something to do with it. Thank you very much. And so this evening, we're going to look at three major things in research. That is implementing study protocols. I don't know whether you can see my slides. Please, can you see it?
Yes, we are seeing your slides.
Okay, so now I'll go off camera so that we concentrate on this. Okay, so let me see. I'm trying to get, okay, so please, I hope you can all see.
Yes, I'm seeing from my end.
Okay. So we will look at implementing study protocols, research ethics, participants recruitment, and taking measurements in research. Those are the three. So our objectives will be that by the time we are done with this 1 hour, 1 hour, 30 minutes, we will be able to implement pediatric study protocols effectively, apply ethical principles in research involving children, and use appropriate recruitment strategies for children and caregivers, and also to conduct standardized pediatric measurements. So a question for us all, you can type in the chat. Why do research studies fail? Why do research studies fail? Anybody, you can type in the chat. Why do research studies fail? Okay, they were not planned properly. Thank you. A very major cause because we don't do it well. Thanks for typing in any third answer so that we can move on. Okay, so I'll just take the two and then let's move on. So by way of introduction, I want to introduce us to a scenario, and it reads, Amma is a 2-year-old girl who lives in a small community. Her mother brings her to the district hospital because she has been losing weight and has had frequent infections over the past few months. At the hospital, a team of researchers is conducting a malnutrition study to better understand the causes of undernutrition among children under 5. Amma appears to meet the criteria for the study. So the research assistant approaches her mother and explains that the study involves measuring the child's weight, height, and collecting some health information. The mother agrees, and Amma is enrolled. During the study visit, Amma's weight and height are measured by one of the field workers. The information is recorded and later entered into the study database. Weeks later, when the researchers analyzed the data, Amma is classified as severely malnourished. Based on the study results, the research team reports a very high prevalence of severe malnutrition in the district. Health authorities begin planning interventions and allocating resources based on these findings. But months later, during a quality review of the study, the team discovers something troubling. Some of the weighing scales used in the field were not properly calibrated. Several children, including Amma, may have had their weights recorded incorrectly. This means that Amma may not have been severely malnourished after all. Yet decisions about health programs, funding, and policy were already influenced by the study findings. So, if I may ask, what went wrong in this situation? What went wrong in this situation? Anyone guess at least one answer? What went wrong? What went wrong in Ama's situation? At least one person should let me know you are listening. What went wrong in Ama's situation? Okay, poorly calibrated scales. Thank you. So let's look at a few of those things. What's made it go wrong? One, some children may have been misclassified. It's been wrong. It's gone wrong because of the measurement errors. Now, someone is not malnourished. Here you are saying the person is severely malnourished, and interventions come in and they classify the child as that. And so the child will receive an intervention that is not necessarily meant for that child because of measurement errors. Then health resources may have been allocated incorrectly. That's what happens sometimes. We over-report that this is the prevalence of, say, malaria in a district, and that is not so. They will give you the resources, but you know very well that these resources are even over-allocated, and sometimes too, because we of errors, we may have less resources because we do not present the data as it should. And so its measurement is very important when we are conducting research. The credibility of the research team could be questioned. All of this happened not because the researchers had bad intentions, but because key research procedures were not implemented. So we ask, what systems can we put in place to prevent situations like AMES from happening in our research? And to put on record, there are so many of these which are happening in our various hospitals in our communities. The measurements, do we have the tools calibrated, as somebody wrote, that sometimes it's not calibrated? So you classify people wrongly. And let's look at the interventions we even give to such people. Are we doing the right thing? Are we really doing the things we have been called to do? That is to guard patient safety. If we are measuring wrongly, and so that's why we are here today. We are here to look at what we are doing wrong in our research. How are we gathering data? Are we doing it right? What can we do differently after today's lecture? What can we teach someone who is also into research to tell them that, look, this way and that way isn't the right way, how would we come together as a team, as a unit, as a department to be able to collect accurate data that would inform the interventions which the government gives us, or inform even policy, or inform global health policies? It all stems from how we are able to collect these data. And so this is a very important lecture for all of us as researchers. And so we will start with the implementing study protocols. This is a major step because that is where the errors will start if we don't have study protocols. But what is a study protocol? It is a blueprint for the research. A blueprint. You all know that before we start write any research, if you are writing a grant, there would be a call that maybe they are inviting calls for people to write into, say, sepsis, pediatric sepsis. And they will give the guidelines for whoever is able to meet the eligibility criteria. If you meet it as an institution or a unit or a department, you can apply. However, what reviewers will be looking out for is how are those who are applying going to implement the study? What tools are they going to use? Who are their target group? What limitations would they likely foresee? And what will be the impact of this study? So if a reviewer sits there and is asking him or herself these questions when your paper is in front of them, what they are looking out for is the blueprint. What is your protocol saying? And so this will be able to take for someone who is giving out a grant to give you that grant. But if you don't have a blueprint, something that is accurately spells out step by step how you are going to conduct this research, or how procedures are being followed in a particular unit, or regards a particular disease, nobody would give you such a grant. And so this makes everyone who is on board here thinking of research, thinking of applying for grants, thinking of doing an implementation research, any form of research, even if it's a pilot, the protocol is very important. And it's a guide for the research team. As a principal investigator, if you don't have a correct guide for your research team, then it's a failed research project from the start. And it's a document that ensures quality and consistency. If you have that blueprint, you can always go back to it to ensure that you are adhering to the protocol, to ensure that quality is not compromised, and also you are being very consistent with whatever you have said you will do. Is it the measurement, taking of the measurements? Is it the data collection procedures? Is it the sampling? Whatever you have envisaged to do, it should be clearly written out in the study protocol. And so that is what a study protocol is. And so the key components of a protocol, I've mentioned them, but I'll go over. You need clear objectives in your protocol. You need the study design. How are you designing it? What methods are you going to use? Is it going to be a qualitative approach, quantitative approach? The protocol must have all these written in it, so that if someone is reviewing your grants, the person is able to tell that, oh, we are looking for qualitative studies, or we are looking for mixed method study. Here is someone with just quantitative or just qualitative. Okay, sometimes they can invite quasi-experimental studies. Are you doing a before and after? Do you meet that? The study design should be talked about clearly so that the reviewer would know that, oh, this protocol is what we are looking for. Then you have to look at your population. For us in this context, mainly we deal with children, but there are times that it's not only a child, it's a child and a caregiver. And that is what mainly child research or pediatric research involves. It's not just the child, it's the caregiver is involved. It is the family is involved. But how do we count them as part of the population? They all matter. Will you detail it? If data is being collected in a household, is it just the child that you are looking for, the child under 5, or you are looking for all children under 5 in the household? Or do you have an assumption that if I pick this child under 5, the assumption is that other mothers will copy from a mother whose child is potentially part of our intervention study. This should all be spelled out. So the protocol mentions all these and data collection procedures. What measuring tools are you going to use? How are you going to validate your tools? How are you going to pilot? Who are you going to involve in data collection? They should all be spelled out. What languages is the data collection tool, your questionnaire? Is it in the language that the one collecting data could clearly read and explain? How are you consenting? They are all parts of our data collection procedures, and they are written clearly in the protocol. And then you should have an analysis plan. We don't just collect data and then put it on the shelves. And so your protocol should have the analysis plan that should tell us that we are going to categorize children according to their malnutrition status, whether they are stunted, wasted, or they are underweight. That is how we are going to do it. But how are we going to do it? Are we going to calculate the z-scores? And how are we taking the height? If we are taking the height, what means? What tools do we have? So these are all questions we ask ourselves as we write our protocol. And so the protocol is a very important tool. You don't skip a protocol. You make sure you spend a lot of time on the protocol. Anybody who is here and is undertaking any research, I want to admonish you and plead that you always spend a lot of time writing your protocol. You spend time putting down what step would come after which step. Otherwise, it wouldn't help your project to succeed. It can let you stop at a point in time. And so this is a very important one. So why is it important to have protocols in pediatric research? I've tailored it to pediatric research because of the audience. So one, to protect children. Secondly, to ensure reliable findings. So if your protocol says that you are going to take measurements, and for every child whose weight is going to be taken, they should take off their footwear. They should wear something very light. Another will come and say, you should be, the child should be naked. An infant should be naked for us to take the length, for us to do this. When we go back to your protocol, will we be able to trace that this is exactly what you have written? Is that what you have trained your research assistants to do? And so the protocol is your fact. If a lawyer gets involved, what is the thing that would say that this is my case? This is the case I have. This is what I wrote. And this is what the participants complied to doing. Or this is what a caregiver said that we could add the child to our study or our survey. So it's a blueprint and it's very important. And to maintain ethical standards. That's why every institutional review board, ethics review board would ask for your protocol. They would ask, where is it? What are the standards you are going to follow? And they would ask how the participants will be protected in this regard. Very soon, we will get into the ethics of this. And then to improve data quality, of course, we want to have quality data so that we don't misinform, so that we don't miscalculate, so that we don't put our participants, our children under any form of danger. We have to protect them. And so the data we collect is essential and must be of high quality. And so let me read another scenario. I said we would have a lot of stories and experiences to share with this. So a hospital is participating in a multi-site study evaluating a new treatment for severe childhood pneumonia. The study protocol clearly states that children must meet specific eligibility criteria before they are enrolled in the study. One evening, a pediatric resident encounters a very sick child with severe pneumonia. In the emergency department. The resident believes the child could benefit from the new treatment being studied. However, when reviewing the protocol, the resident realizes that the child does not meet one of the inclusion criteria required for enrollment. The resident faces a difficult situation. The child is severely ill, and the parents are desperate for treatment. The resident wonders, if this treatment might help the child, should I enroll the child anyway, even though they do not meet the study criteria? What is the issue in this situation? Can I have any answer to this? What is the issue? Please, you are permitted to type in, or you can even unmute and let us know.
Let's make this interactive. So type in the chat box, or you can unmute and then let's interact.
Yeah. Please, I hope you got the story.
Yes, we got it.
Okay, so it's a very interesting story, and we are often caught in such situations. So it's an issue that must be discussed. The child is severely like ill, and you just feel like the child should need this and must be a part of the study. And so the resident feels, oh, why don't I enroll the child? What do we foresee can happen? And what is the issue, or what is the issue you are thinking of? Please,
Yeah,
anybody
hi.
can speak.
Hello.
Hi.
Yes, so I mean I think that the child doesn't fulfill the criteria. If the resident should, I mean, go ahead and go against the blueprints and the child dies as a result of that. I mean, it might not be because the drug didn't work for the child, but
Mm-hmm.
maybe she didn't follow the lay down or the blueprints guiding the use of that drug. I mean, the flip side is that if the child also gets well on the drug, is it the drug alone or the previous is more or less coming to take the all the glory thereof? So it's very difficult to lay claim. I mean, ethically, you would also be going against what you put together to do if it goes either ways. But yes, I mean, if the child dies without receiving the drug too, you are the resident who might be thinking, well, I could have acted and I didn't act. So yeah, those are the issues that may arise.
Okay, so I thank you very much, Bright. I thank you. And that's an interesting one you brought along with all the scenarios. What if the child dies along the line? The resident may think, oh, why didn't I act fast? That could have saved. And on the other way around, if the resident adds the child and something happens, it's also still the same issue. Someone said the resident is assuming the study intervention may be helpful when in fact it's still experimental. Going against the protocol may compromise the safety of the child or compromise the study findings. Very true fact. Then issue is adherence to inclusion criteria for the study. Indeed. So let's progress and see what happens. Okay. So, oh my thing is on. Okay, so one, the child does not meet the eligibility criteria. Enrolling the child would violate the study protocol, as has been mentioned, and this could compromise the integrity of the study. Integrity of the study. Often, this is a question we don't ask, but it is very important. Are we compromising? Just bringing the child on board without going through the processes, the integrity of the study is already compromised. So a lot of times we do certain things that compromise the integrity of a study by not going according to protocol or not taking our time to go through. Sometimes it's either the consenting procedures, or sometimes just not having the time. You feel time is not on your side. You have a 2-year study, and it took you 1 year to get ethics approval. And now you want to get your participants on board because people are on your neck that you have to provide reports. You have to give us the technical reports, especially if it's a funding from some of these big like NIH or NIHR. You will produce a lot of reports, technical reports, media reports. They are on you, and they are asking for impact already when you haven't collected data. Ask yourself, what would I do so that I will not compromise on the integrity of the study? Would I report on everything? Let's continue with our story. What did the resident do? So the resident considered enrolling the child anyway, thinking that it might help save the child's life. However, doing so would mean deviating from the approved study protocol. What should the resident do? Follow one, the resident should follow the protocol strictly. That is what the resident should do. The resident should consult the study investigator. And this goes to all of us at every point in time. You may be tied down by something to ask yourself, should I continue? Should I discontinue? Should I enroll or I shouldn't enroll? Should I invite or I shouldn't invite? Should I even withdraw or not? These are questions sometimes which are beyond our control, but we should always remember that the study also has a team. You are not alone on the team. Your research assistant shouldn't be working alone. There should always be that supervisor or that coordinator who understands the protocol very well. Some people even have quality assurance officers in their research teams who is ensuring that we are adhering to our protocols. We have monitoring officers or monitors. A place like Intampo Health Research Center, it has a room which is dedicated for monitors who are monitoring what is going on in a clinical trial or even in a community survey in the hospital they have. So everything is monitored. And so when you are caught up, like the resident, you need to consult your study investigator. So if this is a mentorship session, one of the mentorship tips we are giving off this evening is that be ready to ask your leader, your unit head, your head of the department. Be ready to ask your in charge, ask your medical soup, the one who is in charge of, let's say, the study, or ask the investigator, the principal investigator. This is the issue I'm being confronted with. Would it compromise the integrity of the study? Before you move on, when you get caught up like this resident, don't feel shy. Go and ask. That is how you would know. And so this is a mentorship tip for the evening. Then provide standard clinical care outside the study. So it's not by force that everyone should be part of the study. There are already clinical procedures ongoing. So why don't you adhere to that? Then document and report any protocol deviations. If you deviate, make sure that you write it down, especially when it comes to clinical trials of say make a trial of a medication or a drug. You want to report every deviation. It could be deviation of temperature, deviation on the field, deviation of maybe giving someone's say drug to another if the person is not in a blinded group or it's in a placebo team, and you go and give something that doesn't belong to that intervention group. These are some of the deviations we record, and you must write it out. It all helps when you are analyzing data. When you are analyzing, you're able to say that, no, this is what happened along the line. So maybe we take out that and analyze the data. But if those deviations are part of the data, it will pull it. Any statistician will tell you, it will pull the data, and you may not get the accurate results as you desire. And so protocols are designed to ensure scientific validity and participant safety. Deviating from the protocol without proper approval can compromise the study results. It will create ethical concerns. This one, everyone would understand this. If you do that, a child who wasn't part of a study and you just because you feel the child is dying or the situation is getting dire, then you say, oh, it's a sepsis study, so let me just add the child. If anything should happen, you have a lot of questions to answer, right from hospital management. You would have a lot of audits, reports to write and to fill. And we know some of these things can be so daunting. So we would not like to have ourselves to blame in such situations. And then we have the violation of regulatory requirements. There are certain studies, when you are going to conduct them as a researcher, we all know the stress we go through, going through FDA approval. I don't know if anybody has had any research that you've conducted and you needed FDA approval. Please, anyone to share any experience on this? You can unmute yourself and let us hear if you've had any experience with applying or applying for approval from a unit like FDA. Anyone? Oh, nobody has had that. So if you get to experience it anytime, just look for me and tell me how it looked like being applying for ethics and having a regulatory body a part of it. They are there to help you. And so the questions they would ask and the kind of details FDA would require, sometimes you would sweat, but that is what would make your protocol stand out. And so we can't run away from these regulatory requirements. And so you don't have to compromise on what has been written. When challenges arise, researchers should consult the principal investigator or ethics committee rather than making unilateral decisions. Okay, and now we look at a very important aspect of our daily research. We can never work in silos. You cannot say that I'm the principal investigator and I'm working alone. You cannot be in the ward and be, let's say, on the field at the same time if they are collecting data from the community. You need a team, and a major stakeholder in our research team are field workers. But we've had a lot of compromises to our data because of the field workers we have. Sometimes our field workers are nurses, the nurses in the wards are field workers. We call it field here because the hospital is our field at this point in time. If you are doing any pediatric research in the ward, could it be the intern, or could it be a national service person who is working there? A team of, let's say, residents could be collecting data. In this case, we'll call all of them the field workers. Sometimes they skip some questions and will not follow sampling procedures. They may not record data, and later some will sit somewhere. I don't know. We've had a study before at Asante Achimagogo where we gave mobile phones in an M-Health research. We gave the mobile phones to the research assistants. And so they were to keep it for like 3 months and collect some socio-demographic data. This was a study on seasonal malaria chemo prevention. And they took the phones with them. And at that time, it was one of the flashy smartphones that were given to them. Many of them had yams. So they saw it a great privilege to be using that in the community. What they didn't know we had done was we had put some GPS characteristics and in that. So wherever they were, we could see it on our dashboard. And then we realized that in the evenings around 5:30, we will see a lot of data coming in. And you're like, in the morning, nobody's collecting data from the homes. In the afternoons, no. Why is it that around 5:30, 6:30, this is what happens? And we will see that they are all taking the data from around a school. The GPS shows where they are, and the coordinates showed us where they were really doing this. So we sent one of the supervisors to the community to get there around the time, not knowing that these field workers thought they were so smart. So they will all go there and try to diversify the data. They will say that, oh, I am writing age 2, you write 2.5, and this one will write 3, and the other will write 4. And they would try to make a few deviations because it was for children under 5. They would try to pick in someone who is some months over 5. Meanwhile, we didn't want anybody beyond 59 months. So if they picked somebody who was 60 months, then it meant that they had deviated. So this the coordinator got there and realized this is where they were standing to give us our data. What do we do? It was a very big blow, but this goes a long way to tell us that the data, who collects the data, is very important. How we train them and some of the things we put in place to make sure we are getting valid data, to make sure we are getting accurate data for the research we are doing and to be able to analyze it for the right interventions for our patients is very important. Now look at what our field workers did. What problems could have arisen? They were giving us false data. And this is not limited to us. Even in the hospitals, we've had people collect data. They just come in and write anything because you are worrying them. The in charge will come and ask for it, or the principal investigator will come and ask, how many patients have you seen this morning? And how many have you maybe put like recorded in the system? And people are like may put in just anything because of supervision. And one of the challenges we have is when people are being supervised, sometimes they may feel that it's daunting and so they may do anything. So an advice again for anyone who is like being mentored this evening is that keep an eye on who is collecting the data. Have quality assurance systems and make sure that you are validating whatever is going on. If it will take you pains to even look at the data that is coming in daily, develop things like dashboards, like what we did, to be able to know that they would stand somewhere and do this so that we could reverse all these. Otherwise, we would have presented data. And the data they were bringing in, it looked very interesting and nice. And they seemed to know the answers we wanted. And so they were giving it back to us. And this could raise a lot of problems. But then we know we are a group of people, Pediatric Society of Ghana, is to ensure patient safety and to make sure that we are collecting data that would, at the end of the day, change a life or save a life or improve upon the health conditions of our children and society at large. And so this is a very important aspect we have to look at. How can this be corrected? This would lead to bias in our results and so data inaccuracies, ethical concerns, and loss of credibility. It can be corrected through supervision, training, and monitoring systems, just as I said. Now, I would like to know some of the monitoring systems you may have used before or currently have. If there's any PI on this call and would like to share an experience, how are you able to monitor some of the data that is being collected? Please, it's open for us to share. I don't want to be the only one talking. Please, anybody can speak. Just unmute and let us know. Or no one has been a principal investigator before. Or if you've collected data yourself before, you can confess for you to be forgiven today. If you've sat at a corner to write before, or you've entered data, you felt, oh, I'm just assuming, looking at the child, this is the weight, and then you just enter that. If you've done that, it's confession time. And if you are a PI who has monitored something before, please share your experience. I can see Dr. Sheila is on board. As for Dr. Sheila, I know you, so I think that I know you can share an experience. Dr. Sheila Usu.
Sorry, Sorry, Princess, please, I missed the question.
Okay, so I'm asking if you have had any study, you've been involved in any research study that had monitoring systems to be able to monitor your data that is being collected.
Oh, yes. Yes. The clinical trials, they used to have a third party monitor. Is it IQUI or something? Yeah, so clinical trial, they had a third party monitor who used to come around and then check if we are following the SOPs and all the other protocols. And then other studies too, where there is a designated data monitor person who weekly generates queries from the red cap, and then you have to answer those ones. Thank you.
Thank you very much. Yes, thanks for sharing that. You mentioned Red Cap. Yes, these are all ways the softwares are now very important and they help us to monitor in one way or the other. There are so many softwares around, and now with AI, if you don't take care, people will sit there and just write in either Claude AI or Cite It or Chat GPT, and then the person will just sit and say, okay, generate data of children who need say malaria treatment, and they are between the ages of 0 and 59 months in a district, and then you tell the AI to generate that data. If you don't take care, the AI will really generate it, and people will fill in this. So what can we do differently to monitor? This is a time for us to look at our monitoring of data being collected. If you are in a project and you don't think there are monitoring systems, please, after today, go back and ask that how are we monitoring the data that is coming in? What are we doing to ensure that the data that is coming in is not being compromised? And is the integrity of our study still what it's supposed to be, or we have compromised it? So go back and ask these questions. And now the best practices in protocol implementation are to train research staff, pilot test tools, monitor field activities, and document deviations, and regular team meetings. This is what we've not touched on, regular team meetings. If you are a PI or you intend to write for a study, for a grant, remember to add team meetings. It is one thing any reviewer would look at. So as we look at research, we are also looking at applying for grants so that we can conduct more research. Remember that regular team meetings is something a reviewer would look out for. And so please take notes. Okay, so pediatric studies often require training on handling children, communication with caregivers, and emergency procedures. We have delved so much into that, and so we'll move on to the next topic, research ethics. So I would like to create another scenario. Please, let's listen and try to contribute to the scenario. It's very interesting. A research team is conducting a study on child asthma management at a busy pediatric clinic. The study aims to understand how children respond to a new treatment plan that could improve asthma control. One afternoon, a mother brings her 7-year-old son to the clinic. The child has frequent asthma attacks, and the doctor believes the study could potentially benefit him. The research assistant approaches the mother and begins explaining the study. However, the clinic is extremely busy and many patients are waiting to be seen. The mother seems anxious because her child is coughing and struggling to breathe slightly. The research assistant quickly summarizes the study and asks the mother to sign the consent form so that the child can be enrolled immediately. The mother hesitates. She looks confused and says she does not fully understand the study, but trusts the hospital and is willing to sign if it will help her child receive treatment faster. Meanwhile, the child quietly asks his mother, am I going to get an injection? The research assistant realizes that the mother may not fully understand what participation in the study involves. What ethical concerns do you see in this situation? Please unmute yourself. I need 2 people. What ethical concerns do you see in here? What ethical concerns do you see? Or should I go through the list and just mention names? Should I be a lecturer here or a facilitator?
Yes, let's
So
unmute
I
and
am
speak.
Dr. Dominic.
Okay, yes,
Back to
doctor.
you. So I think the mother is trying to consent without having full knowledge of the study. So we
Mm-hmm.
cannot qualify this as an informed consent. So that's my input here.
Excellent. I like the word informed consent. It's not just consent, but informed consent. Yes, thank you very much. Dr. Dominic, yes, please. Any ethical issue you also see? He has spoken on the side of the caregiver. So who else would let us look at any other concern? Okay, this says we all side with Dr. Dominic, right? We will progress because of Sheila. I see your hand is raised. Please go ahead.
Yes, so I missed the age of the child, but then I think an assent in this case, based on the protocol, like if the child could understand, maybe if the child is more than 7 or 8, then the child would have to provide an assent.
Okay, so thank you very much for assent. Indeed, this was a child who didn't want to get an injection. So another thing in research is that if it's a child, the reason why we call them vulnerable groups is the fact that they are also not able to provide consent for themselves. And you mentioned assent. Assent is actually for those 16 and below. Anybody who is 16 and below, you have to provide assent. Not you can't give consent. So still, those in the senior high school now, it's you have to have a parent or a teacher sign. They do not sign, so it's still an assent. Thank you very much for bringing that in. And so let's look at what ethical concerns we see. The mother does not fully understand the study. Consent may not be truly informed, just as you mentioned, Dr. Dominic. The mother's decision may be influenced by the agency of the child's condition. And I must say that in the hospitals, this is mainly one thing that would coerce mothers into or caregivers into allowing their children into a study. And I remember malaria vaccine trial, a clinical trial, one of the biggest clinical trials in Ghana, which I was involved in. You know what was making the mothers consent? Sometimes it was just morning, you'll be giving cocoa with kosi. So they had breakfast for their children. And whilst you are there waiting, they are taking the measurements and all that. The mother is giving lunch provided for. And before they leave, they have another cocoa and kosi. This was meant for the children actually, but caregivers were given. And we could see a surge in the numbers. In this case, some of them said that it's cocoa 19 nearby. So it's because of the cocoa we are coming. At least we are able to provide food for them. They have been coerced because of what they were given. We will look at all these things. Should we do things to coerce them to get into the studies, or we should allow them? Should we take out the compensations? Are they all necessary to also get us recruits in this part of the world? Our context really matters in this case. Sometimes we all argue about what we should do, but is it right? Let's look at the ethical consent. Then the child's assent has not been considered. So thank you very much, Dr. Sheila. What you said exactly. The child was below age, can't consent for him or herself, and so the child was not considered in giving assent. So the story continues. The research assistant now faces a dilemma. The clinic is crowded, and the research team needs participants for the study. However, rushing the consent process may compromise ethical standards. What should the research assistant do in this situation? I would come in with the answers. What can be done? The research assistant should take time to properly explain the study. You shouldn't be compelled by the situation there that there are crowds. Research doesn't deal like that's not how research is. once there's a protocol that you must follow, that is it. You must follow it. It's just like when you haven't taken, let's say, like you haven't taken certain laboratory tests, you don't give certain medications. That's how it is. You haven't gone through the protocol. Why would you just like to recruit someone? It poses a lot of danger and ethically not right. And so these are things we should take note of. Ensure the mother understand the risks and benefits. We are often very quick to talk about the benefits. Oh, your child would, after taking this medication, he or she will not have any form of childhood illness again. That is it. No diarrhea, no pneumonia, no malaria. And then we keep exaggerating. Anybody who trains research assistants, from my experience, one of the things we can tell them is that, look, exaggerations will not help our cause. We want data of integrity. And so if you are explain as it is. The risks are also there and the benefits are there. Of course, when it comes to certain risks, like when it comes to blood draw, the sociocultural beliefs and others that accompany it are quite a lot. And so all these things, we have to think about it when we are speaking about the risk. Then allow the mother to ask questions. They have the right to ask. Why do you want my child to be a part of this? What do I stand to benefit? Give the mother the chance to ask the question. Sometimes because we are in a haste, or when we look at the numbers that are sitting outside waiting to enter our consulting rooms, we may not have time. We are only looking at the child and the condition of the child, and you are quick to say maybe we want to take the temperature, we want to stabilize the child, and so the mother is just feeble and cannot ask the questions they need to ask. Please, let's give the chance. It's their right to ask the questions before they are allowed in. Obtain assent from the child if appropriate, and ensure participation is voluntary and not linked to treatment access. Participation should be voluntary. It doesn't matter if you are not getting people for your study, you can still report it. It is a form of report. Just report, I'm not able to get the participants, and then you'll be helped. So why ethics is critical in child research is that children are vulnerable participants. We mentioned it. They are dependent on their guardians and they are unable to fully consent. And so it's a critical thing. You don't just look at the caregiver you are talking with, but you are looking at the end result. What would the outcome be in the child who is receiving the treatment at the end of the day? Sometimes some are on, say, placebo. Others are taking the real treatment. And we are trying to compare in a clinical trial to see what is happening. At the end of the day, we are still dealing with vulnerable participants, and it is not the end result we should be overly concerned about. The safety of the child. It's one of the critical ethical considerations because of how vulnerable they are. So children provide assent whilst parents provide consent. This is a takeaway for anybody here. If you are doing research and a child is involved, I said under 16, they provide assent and parents provide consent, because the parents are able to sign and say that I will do it. The assent is somebody is able to say that, oh, I give my child to participate in this. And that is what you would often deal with. The caregivers would assent or would say that I want my child to be a part, to consent. So now let's look at some ethical principles. Respect for persons. You should respect who, no matter where they are coming from. A lot of the times, we've done some research studies, and you go to a place, and they are saying that because I'm from here, they didn't look at me, they didn't do this to me, and they attended to this person and all that. Even in research, we are bringing people out of the queue and attending to them and leaving us others. Respect for everybody who is a part of it is essential. Beneficence. What is the benefit? Will your people stand to benefit from it? We have to let them know, what are you getting from it? What are the risks? We've mentioned them. The justice. If you are applying this, like, don't say that those in this district, they deserve to have a placebo, and another group of children deserve to have their true intervention. In research, we don't do that. That's why randomization is very important. It's a key thing. If you are doing a clinical trial, sometimes we have to blind, not just blind, you have to do double blind. And sometimes the investigator is also blinded. Everyone who is privy to the treatment is blinded, so that you don't know who is taking what. And that is where makes it a just research study. It's just like you are giving everybody the equal chance. And if the person still wants to withdraw, the person has the right. So let's ensure this. And there's ethical guidance we can get from the Belmont report. If you want to read or you want to do further any research or further talk on ethics, WHO has a very big write-up on ethical principles. If you go to their page, it's actually a book, over 300 pages, then Belmont reports. So these are what we can do. A mother, we have some minutes more. A mother is asked to enroll her sick child into a study, but does not fully understand the study. That is what we are just talking about. What should researchers do? What should be the ethical approach? So in this case, let me invite another answer. What do you think should be the approach to such a study? And especially those of us who work and are surrounded by people who may not be literates, or people who are coming from, say, the villages, people who don't really understand what research is. How should we go about their consenting processes, or if we are looking at the issue of ethics, how should we deal with them? Any one can share with all of us. Anyone who has been in research, how would you normally deal with this group when it comes to issues of research ethics? You'll be done very soon, so please share so that we can easily wrap up. Anyone to share, or I should mention a name again? I'm seeing a name that is familiar. Dr. Atobra. Dr. Atobra, do you have anything to share? Okay. Oh, my participants, please mind me. This one, I wouldn't move. I want to hear you. Issues of ethics, particularly with the kind of participants or patients we see. Anything, just anything surrounding research. How would you consent? How do you get them to understand and even participate? I want to hear your version. I've given a lot about clinical trials and being in the communities. Okay, maybe this is to say that nobody has led one before, so we are all learning. I'll move on because of time. So first approach is you have to clearly explain to the caregiver. You have to allow time for questions, and you have to avoid coercion. What coercion is doing something to entice someone to be a part of the study. For instance, a coercion could be, oh, if your child gets on this, they will never convulse again. Giving certain statements that will make ordinarily any mother would decide to be a part of it because of the statement you make. And so it's not right. It doesn't sit well if you are a researcher. So anyone aspiring to do research or is a researcher, coercion shouldn't be the case. You shouldn't say that you are recruiting children into a study, and the first thing you do is go and put Indomie, you are making Indomie for children who will come. They will definitely say they will be part of this. So it's a form of coercion. We don't do that. That is why any ethics committee would ask you, what compensation are you giving to your study participants, for them to see whether you are coercing them or you are just giving them something to compensate for the time they have spent with you, or for maybe even the pain that they have been through a blood draw. Then ensure voluntary participation. That's one we've really talked about it. Allow them to say, I want to be part. If they say they don't want to be part, allow them. Now, we've talked about parents or guardians are very critical in ethics. The child assent is very important. The community trust and cultural sensitivity. It is highly important. Cultural sensitivity, community trust. Cultural sensitivity, community trust. We cannot move away from these two. And this leads us in Ghana, community leaders and health workers often play a critical role in recruitment. Community leaders. So you may be in the hospital recruiting, but there may be somebody in the community, a leader who is pulling the strings and saying, don't even go to the hospital, or in this community, these are the rules we are bringing in, these are the laws. So community leaders are giant stakeholders. So this is also another scenario I created. Since my participants are not enjoying my stories with me, I'll enjoy the stories myself. A team of researchers is conducting a study on childhood vaccination attitudes in a rural community. The aim is to understand why some parents delay vaccinating their children. The research team arrives at the community and begins approaching parents at a local health outreach program. However, something unexpected happens. Several parents refuse to participate. One mother says, we have seen researchers come here before. They ask questions, take our information, and we never hear from them again. Another parent says, are you going to use our children for experiments? Within an hour, the team realizes that very few parents are willing to participate in the study. The team leader begins to worry that the study may fail because they cannot recruit enough participants. Why do you think the community is reluctant to participate? Why do you think the community is reluctant to participate? Please, this is a very simple one. I just want to hear another voice apart from my own voice. Pardon?
Lack of trust
Lack
in
of
the
trust.
researchers.
Lack of trust, a very big issue. Lack of trust. And that is the first. Okay, Dr. Sheila.
I was going to say they didn't do a proper community entry.
Excellent. Another thing, anybody who has done any form of research here, even if it's in the hospital, you will still trace it to community level. And so this is a very important part that we must all adhere to: lack of trust, poor community engagement, previous negative experiences with researchers. Let's note that the kind of this one, it is what you reap what you sow. So if a researcher goes in and then gives bad experience to people, if we go there again, we will have a negative experience. Then fear of misinformation. I have a very interesting experience of not engaging community properly. So in one of our studies in a rural setting, it was mainly almost like it was a slum setting. In that, we went there and we were, it was a clinical trial. So we had three, that was using the DHAP-KO, then artemisinin-based combination therapy, and we were using vitamin C as a placebo for our participants. We were going to engage 2,400 children. The first time we went to enroll, we had, the enrollment was almost twice the number we needed. Then we gave them all the orientation, the education, the information they needed. We had our consent form signed. Then the day we announced, a day before, we made gong beaters go around the community. They informed everyone. They told them that the team of researchers from KNUST will be here together with people from University of Pennsylvania. And there we were. We were there with our bus, and we brought in community people to help. So they were there recruiting, or when they come in, some of the community members would write and register you because they knew you. And we didn't want certain communities to be part because it was a cluster. And we didn't want to have any contamination. In research, we say contamination because someone might have come from another place district, which is not an intervention district, and say a control district, and then they come in and they contaminate the data. That is how we call it in research. So if we decided to use them so that they could control that for us. And on the first day, the turnout was very good. Second day, the people had changed. The people were using, some didn't come, some came. And we would see people coming in and draw back. They would go. They wouldn't get to our place. The second day, we had a very poor turnout. And when we decided to debrief as researchers, one of the very important things to do, to debrief after every day, we debriefed and we saw that no, there was something wrong. It can't be. So we decided to engage one of the people who had been our liaison in the community for, I think, quite a number of years. And then this man tells us that, hey, today, the one who was standing by the vitamin C, helping the nurse who was giving out the placebo, is the son of the fetish priest. And so the people were like, hey, you are drawing blood, and the fetish priest son is part of this study team. So this shows that we didn't properly enter the community, and even the people who were using, we hadn't really scrutinized, or we hadn't really done any background checks on the people. And sometimes those are the mistakes we make. This is a hard lesson I learned, and I began knowing the essence of engaging properly. Not just engaging as in, oh, we are coming here, we are introducing our team, we want to come in here for about a month or 2 or 3, and this is how it will benefit your community. This is what resources we are bringing into the community. This is how it will affect policy. It will affect our relationship with you. None of this. It should also be, who are the people we are engaging in the community? What are their backgrounds? It's very important. And sometimes we engage them because you want your research to move, because they clearly understand what goes on in the context in their community. So it's very important. Our time is running out. So one, we have to learn to engage community leaders. We have to work with local health workers. Don't just go in and say, oh, I brought my whole team and I want them to do everything. They can't do everything because they don't know the context. They don't know the barriers or the obstacles that could come in. And if there's an obstacle, who is there to help? Explain the purpose of the study clearly and provide feedback to the community. Let's do that. Let's learn to give feedback. You don't finish a study and then it's just on your laptop and you are traveling to Ethiopia, you are traveling to American Society of Tropical Medicine and Hygiene, presenting, going here and there, and they hear their names out there and they have heard nothing about it. They don't even know the results. And that is not good on our part as researchers. Anybody being mentored today know that feedback is critical in research. Then address misconceptions. Now let's look at quick recruitment strategies. We can recruit in hospitals and clinics. Apart from the immunization centers are places we can recruit. We can recruit in schools. We can recruit during a community outreach and on digital platforms. So anybody who is here applying for grants, use different strategies. Don't always say that I work in the hospital and so I want to do everything there. Sometimes the interesting things or the gaps that remain are in the field, or you even hear them from the caregivers, and then you trace. Sometimes you have to trace through qualitative studies and ethnography. You have to do all these to be able to recruit people. So let's move out from our comfort zones. Let's step out, apply for grants that would help us to look at other areas, and it will even inform our clinical work and help us to be able to engage properly. Now, some of the common measurements, of course, we all know: weight, height. We can't run away from all these: mid upper arm circumference, mark, the temperature, then developmental assessment. These are what we do constantly, and they are very important. All these are data which are relevant. Standardization is important to ensure accurate measurement. Calibration. Our first scenario showed that training is highly important. Then quality control, the monitoring and the evaluations that we do. Incorrect measurements can affect diagnosis and mislead research findings. Let's always remember that what I'm doing, if it's not correct, it will affect diagnosis and it will mislead research findings. So this is also another error that happened, and it was about measurement error. And the problem was that they had allowed some people to wear like their clothing to be able to take their height, others not. So the whole data wasn't standardized. Not making it standardized means you didn't use the same lay down procedure in collecting your data. So it's not standardized. There's no rule to follow. This makes our protocol again very important. If you are a team leader, you have to take time to make sure that your tools are standardized and the data you are collecting. If someone is not wearing shoe, all of them should not wear. If you are removing their clothing, they should also have their clothing removed. And lack of standardization in measurement procedures, it's very critical. It doesn't help. So what is the line of action? Establish SOPs for measurements. Ensure all children in that scenario remove shoes before weighing. Provide refresher training. Sometimes when they err, you have to keep training. Don't say that, oh, they are doing it, so they are experienced. The experience, sometimes it goes with a form of complacency and we end up not doing it well. But we have to know that sometimes we get it wrong. And the more we refresh, we are able to get our data collected rightly. Conduct supervision and quality control checks during field work. And if necessary, repeat measurements that were taken incorrectly. What other types of measurement errors might occur in pediatric research and how can we prevent them? We have to calibrate our equipment. Incorrect positioning of children during height measurement is often done, and we have to look at it. Anybody who is a trainer here, always in our periodic trainings, we have to add some of these things. Once in a while, add recording of measurements and recording of data to some of the things we do. Just make it practical so that all of us will learn. And if you are a principal investigator, still be a part of the process. Sometimes do it yourself. Be a part of it, because of late I've seen that when you are collaborating and they come, they want to see what you can also do. And if you can do it, they are assured that you are able to monitor and you are able to validate what is on ground. And differences between measurements should always be seen. I think that, so what's the importance of standardizing? It ensures accuracy of data. It improves reliability, that if I do the same measurements, I will get it like under the similar conditions, I will produce similar results. It's not that somebody is weighing 5.6 kg and then the following day the person comes and weighs 8.6. That is not the right thing. And this is a problem we have. Are we calibrating as standards authority? How are they monitoring all these? And even in our own consulting rooms, our hospitals, how are we ensuring that our data is reliable? Allows comparison across sites and researchers. And then it also protects the integrity of our research, what we've been drumming the whole day. We want to protect the integrity, so standardization is very important. And now, as we get to the end of this, I want us to look at some key takeaways for our research as pediatricians. What are we taking away today? One, ethics must always come first to protect the rights, the safety, and the dignity of children. And we have also learned that obtain informed consent from parents and guardians and assent from children where appropriate, and ensure confidentiality and minimize risk. Recruitment requires trust and transparency. This is the case of our communities. Engage. Ensure voluntary participation without coercion, and let's communicate clearly with caregivers. Let's take our time and communicate clearly. Then follow study protocols and standardized measurements. Adhere strictly to approved study procedures. Train research staff adequately. This one, I will say it over and over again. Train and retrain and refresh the training. It's very important, and use standardized tools and methods. Let's take time. Sometimes we need to take the tools to the standards authority to be able to calibrate or to ensure that they are all standardized. Let's do that to make sure we are getting our data. So in conclusion, high-quality pediatric research depends on ethical practice, effective recruitment, and strict protocol implementation. These principles ensure that research findings truly contribute to improving child health in Ghana and beyond. I will always end by saying that I don't see what remains to be done. I don't see what has been done. I always see what remains to be done. And what remains to be done is for we researchers to uphold all that we want to do to make an impact, not in the life of the people around us, but in the patients we see and the people we come into contact with, in the communities we find ourselves, and in the country we find ourselves. What do we have to contribute? As researchers, we have a big role to play in informing policy, in changing policy directions, and making sure that the interventions that are being brought are making the accurate impact they deserve. Thank you very much for giving me time to share on these three important topics. And I believe that you have learned something. I would give room for questions. Dr. Rafik, please, I think I would invite you to help me with this session. Thank you very
All right.
much.
Thank you very much, Princess, for that insightful presentation. I was wondering how you were going to be able to combine those three topics and still do justice to them. But at the end of your presentation, we can all attest to the fact that you have done justice to them. Please, if there are any questions, any contributions, any clarifications, we can unmute and speak, or you can raise your hand. I will call you and then you ask those questions. And then for the next 20 minutes. So questions. You can also type your questions in the chat box and I will read them out. So questions on anything probably might not be limited to just these three topics. Princess is a very seasoned researcher, and I'm sure she can handle any question on research. So even if it is not on the three topics she has talked about, you can ask them. Hey, why? You have no questions. You understood everything perfectly. So, since we have understood all that Princess has taken us through this evening, I'm happy and I hope that we will be applying all of the knowledge that we have learned in this and the previous sessions. So we have gone through formulating your research question. We have gone through writing up your research protocols. We have gone through applying for ethics approval. And today we have gone through three important topics: implementing your protocol so that it actually measures what you set out to measure, and that your results will be representative of the community in which you did your research, and also ensuring that you make those measurements and implement your protocol ethically. So, if there are no questions or contributions, I would like to thank Princess once again for taking the time to prepare this insightful presentation. One of the aims of this research mentorship program is that after the lectures have been delivered, we will make a call for members who have research ideas and protocols to implement. And we will assign them to mentors who will help them to develop these protocols and implement them. So, Princess, I hope you will be interested in mentoring one or two members of the Pediatric Society when we get to that stage, so that we can make use of the knowledge that we are gathering in this lecture series. So, Princess.
Yes, please. I think this is what I do, and I will gladly be a part of this. I am looking for more mentees. So thank you very much.
Okay, I hope I didn't put you on the spot.
Oh, not at all. This was expected.
All right, all right. Thank you so very much. And I hope all our attendees enjoyed your lecture. We will be calling on you once again when we need your help. And we'll be bringing the meeting to a close now. I can see Kingsley is on the call. Even though we didn't start with a prayer, I will call on Kingsley to give us a closing prayer. Kingsley, are you on the call? Are you listening?
Yes. So please, shall we pray? Father, in the name of Jesus, we thank you for an insightful presentation. And we thank you for the opportunity to add to our knowledge. Father, grant us the grace to be able to use this to help humanity. Father, even as we are going to our respective places, may you continually guide us, may you continually protect us. And at the end of it all, may we give glory, honor, and adoration to your name. We thank you for answered prayers. In Jesus' name have I prayed. Amen.
Amen.
Thank you so very much, everybody, for attending. And then, Princess, we'll continue our discussions after this.
Okay, thank you.
Okay, bye-bye, everybody.
Bye.